Examination of periodontal disease. Any patient come to the clinic, he or she is examined by the dentist. The examination of periodontal disease lead to good diagnosis and good treatment. When we do good examination, the diagnosis is perfect and the treatment is related to this perfect diagnosis and examination. First of all, we take medical history. The medical history, either write it by a questionnaire, paper and a questionnaire, or we take the information from the patient and write it down. After take medical history, we should include references to the following. If the patient under care of physician have any systemic disease, have any drug taking, any allergic sensitivity, spontaneous or hemorrhage, spontaneous bleeding or hemorrhage, any abnormal tendency to bleeding, he drug addict or he take some drug as a treatment like aspirin. If the patient diabetic, hypertensive, he has family disease or family history. What is the relevance of patient medical history to his or her periodontal care? Medical problem can increase susceptibility to periodontal disease, like diabetic. Medical problem can have periodontal and other manifestation, like leukemia. Another drug may have oral manifestation also, like phenotype. Precaution to be taken: avoid complication during treatment. Treatment of certain condition may present additional risk to the dental team. Also, in examination, we must take dental history. There is previous visit, if he or she gone to or went to the dentist previously, have any previous treatment, any previous denture, if the patient cooperative or not. So dental history is important. Any difficulties in patient chewing, speaking, painful tooth, if he has previous orthodontic appliance, anything we discussed it with the patient about his previous dental. Social history is very important. If the patient smoker, alcohol consumption, have family problem, sensitive or allergic to drug or any important things that affect the anesthesia of the patient. We must also, after take medical history and dental history, we take impression to the patient and pouring a cast to the patient, and by the cast we can see the relation between upper and lower jaw, and if there is TMJ problem, any problem clear, can we see it clearly. Intraoral radiograph survey, panoramic radiograph, we can see from radiograph if there is bone resorption, if there is any bone disease, interdental caries. Clinical photograph, it's very important before and after. Many psychiatric patients, they say, you do nothing, there is nothing changed in my mouth, so we must take before and after radiograph. Oral examination, very important. First of all, oral hygiene, the clean of the mouth. If he brush his mouth, if he dental aids, dental flossing, interdental brush, etc. We tell the patient and show him the plaque in his mouth, accumulation of a plaque, if there is food debris, if he clean his teeth accurately or not. There is malodor, the cause of malodor, gingivitis, caries, periodontitis, tonsillitis, sinusitis, the many causes of malodor of the patient. Examination of oral cavity, very important, by mirror and the probe. We can see if there is caries, missing teeth, dental plaque, calculus. Also can examine the lymph node. Many diseases have lymph node enlargement. For example, primary herpetic gingivostomatitis, necrotizing ulcerative gingivitis, and acute periodontal disease abscesses may produce lymph node. Examination of teeth, if the teeth is natural teeth, if there is implant, if there is any problem, perimplantitis, gingivitis, periodontitis, plaque accumulation, wasting disease of teeth like attrition, abrasion, any one there. What's attrition? What's erosion? This is attrition due to paroxysm of the tooth, occlusal and proximal tooth surface wearing, or due to conception of like erosion, conception of acidic. Also dental stain, if there is external stain due to tobacco or cigarette smoker, or internal stain due to tetracycline consumption during childhood. Hypersensitivity of the tooth due to gum recession. Sometimes there is sensitive due to exposed cemento. Tooth mobility, also important, examine the tooth mobility of the patient. Tooth mobility due to trauma from occlusion or loss of tooth support, due to inflammation, to periodontal disease. Tooth mobility due to pathological, sometimes natural, in early morning, during period, sometimes there is a slight tooth mobility. Trauma from occlusion, if there is any trauma from occlusion, we can examine first in the first visit of the patient. During examination, sometimes primary trauma or sometimes secondary trauma when there is pathological migration of tooth, also premature tooth contact in the anterior or posterior teeth may due to migration of teeth from his position. Also there is migration due to pathological change in period. Sensitivity to percussion, there is tender to percussion or not. Examination of periodontium disease is very important. We don't buy periodontal probe, special probe, periodontal probe, many type of periodontal probe penetrated in the sulcus or gingival pocket. If there is slight penetration, about 0.5 to 2, it's mean sulcus or healthy tissue. If increase in the measuring, there is a true or false pocket. If there is plaque and calculus in the patient mouth, examine supra or subgingival calculus, the type of gingival inflammation, color of gingiva, loss of stapling, texture of gingiva. If there is any inflammation lead to redness, loss of stapling, swelling, maybe diseased gingiva. Periodontal pocket, also the first sign of periodontal disease, such as color changing and edge or rolled edge of gingival margin. So we penetrate the pocket. If the pocket beyond the cemento-enamel junction, it means migration of junctional epithelium apically. This is loss of attachment. There is a disease. How duct pocket? We said previously by periodontal probe with long axis of the tooth, direction of the tooth, tapering apically, so with the direction of we can penetrate the probe. If stay in the base of the pocket, which is apical to the cemento-enamel junction, this is true pocket. If the pocket on the cemento-enamel junction, there is no loss of attachment. The distance between cemento-enamel junction to the base of the pocket is loss of attachment, while the distance from free gingival margin to the base of the pocket is propping pocket depth. If this distance is equal, it means true pocket, no loss of attachment. If the propping depth less than loss of attachment, it means gum precision. Direction of the probe is very important. With the long axis of the tooth its taper apically, force its point 75. Gentle propping, the weight of the probe, just by the weight of the probe without propping the area. If there is furcation involvement by neighbor probe, we can't see it either by radiograph or exam. Level of attachment, as we said previously, this is a propping pocket depth, and from cemento-enamel junction to the base of the pocket, it's loss of attachment. The difference between two is loss of its gum recision. This is loss of attachment. This is propping pocket depth, and this is gum recision. This is good picture. Base of the pocket, propping pocket depth, loss of attachment, propping pocket depth, no gum recision, propping pocket depth less than loss of attachment, it means gum recision. Bleeding or propping, very important. If there is bleeding, mean inflammation. No bleeding, no inflammation, it's good and accurate measure. Amount of attached gingiva is very important. This is free gingiva, this is a free gingival groove, this is attached gingiva, and this is alveolar mucosa. This is good picture, clear, alveolar mucosa and attached gingival recision, anterior teeth, gingival recision, and posterior teeth. This by radiograph. This is angular bone resorption between two central. Horizontal bone resorption, which mainly appear in chronic periodontitis. Angular bone resorption mainly appear in aggressive periodontitis. Why? Because this is a slow destruction, chronic, that take long period. There is a resorption and remodeling of the bone, while aggressive periodontitis is rapid resorption and rapid destructions, so lead to resorption. Suppuration, if there is suppuration in the gingiva, we can rest by finger and we see suppuration of gingiva. Periodontal index, abscesses. Periodontal abscess is a localized accumulation of exudate within the gingival wall of periodontal pocket. We have acute periodontal abscess, and we have chronic periodontal abscess. Also we have gingival periapical abscess with non-vital tooth, while periodontal abscess tooth is vital. So the main difference is vitality of risk factor. There is many risk factor, mainly diabetic, smoker, age, diabetic smoker, age, systemic disease like any other systemic disease. It's